Welcome to Pharmacology for Nursing Unit 3. We're going to talk about the cardiovascular system, and we're going to start by way of the nervous system. So this first part is going to be not going to really recap the autonomic nervous system. We go a little deeper into the autonomic nervous system than we went before. We're primarily going to focus on the sympathetic nervous system, or the adrenergic receptors. So remember that the adrenergic system is the sympathetic. It's the fight or flight. So these are things that we want that are going to stimulate, increase our breathing, either the rate or allowing more oxygen in through bronchodilation, get our heart rate up, get glucose moving, the things that we need to run away or to punch somebody in the face. So when we're looking at subtypes, types and subtypes of adrenergic receptors, we're primarily looking at alpha and beta. So we have alpha and beta receptors, and within those we have subtypes, which we have alpha 1, alpha 2, and beta 1 and beta 2. And they are all affected by norepinephrine, which we remember is the neurotransmitter for the adrenergic or sympathetic nervous system. Primarily what we see, though, is that they innervate different areas of the body. They have different target receptors, and so they're going to give us somewhat different responses depending on which receptor is stimulated. Now, alpha 1 receptors are in all sympathetic target organs. So anytime we stimulate alpha 1, we're going to get all of the things. We're going to get dilation of the pupils. We're going to get decreased peristalsis, bronchodilation, tachycardia, increase in blood pressure. We're going to see decrease in urine output. All those things that are going to be affected, and you can review. The thing about alpha 1 is this includes the peripheral vasculature, so it's going to cause some changes in dilation of the vessels. Alpha 1, like I said, all sympathetic target organs except the heart. So alpha 1 does not innervate the heart. Alpha 2 receptors are more centrally acting. So alpha 1 goes out to target organs, and alpha 2, we're not going to spend a lot of time on ever, really, are centrally acting. Now, beta 1 and beta 2 are subreceptors of the beta system. Beta 1 receptors innervate the heart and the kidneys, and beta 2 receptors all sympathetic target organs except the heart. Primarily we see with beta 1 changes in heart rate, some effect on cardiac output, and if you remember about cardiac output, it has to do with heart rate. So changing the heart rate obviously is going to change cardiac output. And then beta 2 receptors don't affect the heart. And primarily when we're using a beta 2, we're looking at peripheral vasculature, but we're also going to be looking at the effect on the respiratory system, and that is primarily the bronchodilation. So some commonalities that we want to think about when we're talking about adrenergics is that the dosage affects the receptor. So a lower dose may make it selective so that it may only affect one type of adrenergic receptor, so alpha or beta, or maybe only beta 1 or beta 2. Higher doses stimulate more receptors so that we may give a beta 2 for bronchodilation, but if we give it a high enough dose, then it may affect the heart rate as well. And so we may get bronchodilation, but at the risk of causing extreme tachycardia. So those are things that we have to be aware of as well. A lot of the side effects that we see are dose related. Sympathomimetics, also known as adrenergics, produce the same effects as anticholinergics. This is a refresher. They mimic the sympathetic nervous system. They can stimulate alpha and beta receptors, sometimes all four, alpha 1, alpha 2, beta 1, beta 2, sometimes a single receptor. The thing about sympathomimetics or adrenergics is that they're more specific than anticholinergics. And so because we can target certain receptors, they have wider therapeutic uses. When we target a certain receptor, we're going to have fewer side effects. Whereas when we're using an anticholinergic, we're going to get all of those side effects that we may not necessarily want, dry mouth, constipation, all of that stuff. So adrenergics can affect alpha and beta receptors that are located primarily, the ones that we're concerned about for the cardiovascular system would be the heart, the bronchial tree. I know it's not in the cardiovascular system, but it certainly is going to be affected. Nasal passages, kind of an aside there, and the peripheral vasculature. So, yes, I'm aware that the heart and the peripheral vasculature are the only two that are part of the cardiovascular system, but the bronchial tree and the nasal passages we're going to address as well. So kind of an overview. If they're selective, then we can get them to stimulate certain adrenergic subreceptors. So for stimulating alpha 1, we can use a nasal spray or sometimes an oral decongestant to stimulate the alpha 1 receptors in the nasal passages. This will cause vasoconstriction and cause us to dry up nasal secretions. Alpha 2, we talked about, are centrally acting. The alpha 2 receptors are located in the brain, and we're not going to spend a lot of time on those. Beta 1 receptors, if you think one heart, 2 lungs, then when we stimulate these individual receptors, that gives you an idea of what the therapeutic response is that we're trying to get. So beta 1 receptors located in the heart, they increase heart rate, and they can increase the force of the contractions, both of which are going to increase cardiac output. Heart rate alone will do it somewhat, but if we get more complete emptying of the heart by increasing the force of the contractions, we're going to increase cardiac output even more. And then we stimulate beta 2 receptors. Beta 2 are located in the bronchi, and so stimulation of those are going to cause bronchodilation. So if we're using selective sympathomimetics, then we can get targeted responses. Now, non-selective sympathomimetics can stimulate all the adrenergic receptors by causing norepinephrine to break down into epinephrine. And then, of course, epinephrine is used in cardiac arrest to stimulate the contraction of the cardiac muscle and to increase heart rate, and is used in asthma because it is a bronchodilator. But when used for asthma, it's going to increase the heart rate. It's we need to observe for that side effect. When used for cardiac arrest, it's going to cause bronchodilation. Now, this is a side effect. It's not the initial intent. However, when used in that situation, it's a beneficial thing because the more air the person can get in, the better when their heart rate is irregular at best. And then some non-selectives will stimulate alpha-1 and beta-2, such as Sudafed. We know that Sudafed is a stimulant. It's primarily used in over-the-counter nasal decongestants when you can get it. But because it is a stimulant and it's non-selective, it also is going to increase heart rate and has the potential to increase blood pressure because of the increase in heart rate. So just based on that, you can take another step forward and recognize that people who have high blood pressure or who have cardiac irregularities shouldn't take pseudoephedrine for whatever reason that they might want to take it. And so just based on understanding the action, how does it work at the receptor site, we can gather a ton of information and apply that to our patient population. Now, other non-selectives can stimulate beta-1 and beta-2. Now, by stimulating both of those, we're going to get both heart and lung involvement, but we're going to see an increase in the rate force, increase in heart rate, increase in force of contractions, and it affects the electrical conduction through the heart, which is obviously goes back to increasing the rate. With non-selective sympathomimetics, we're going to see more autonomic-related side effects because they're not stimulating just a single receptor. So we're going to see that constipation, urinary retention, problems with glaucoma. All of those things we're going to see because we're using a non-selective sympathomimetic. Now we've talked about stimulating the sympathetic nervous system. Now we're going to talk about adrenergic blockers. Excuse me. So when we think of blocker, we think inhibition or something that stops something from happening. So an adrenergic blocker inhibits or stops the sympathetic nervous system. In effect, they're going to produce the same response as parasympathomimetics or your cholinergics, which you are familiar with. So when we stimulate the parasympathetic system, that's when we're going to see pupil constriction, constriction of the bronchi, bradycardia, relaxing of the bladder, diarrhea, increased peristalsis. So those are some of the side effects that we would see from these adrenergic blockers because we're going to get symptoms of stimulation of the parasympathetic system. Adrenergic blockers are the most widely used class of autonomic drugs. They have a wide range of use in treating the cardiovascular system diseases. And so we use them to treat hypertension, heart failure, angina, MI, you name it. If it's a problem with cardiovascular, then it's probably an adrenergic blocker that we're going to use. So what does blocking the adrenergic system do for us? Well, it can relax vascular smooth muscle. Remember, when we stimulate it, we get changes in dilation. Well, that change is constriction. So stimulating alpha-1 causes vasoconstriction. That's how it decreases nasal congestion, by constricting those vessels in the nose. And so we get decrease in edema of the nasal passages. And so we don't have decongestion. Well, we're going to see that the opposite happen when we use an alpha blocker. And so by blocking the alpha-1 receptors, we're getting vasodilation because we're relaxing the smooth muscle of the arteries. Remember, the arteries have that ability because they have actual muscle layer to constrict or relax. By relaxing, it opens up that vessel and allows blood to flow through freely. It's a difference between trying to force water through a coffee stirrer, or even to take a drink through a coffee stirrer, versus taking a drink through those big straws that you get in the plastic cups that come with all the big matching straws. So what do we get if we cause vasodilation? Well, we get a decrease in blood pressure. Now, take that a step forward more, and what kind of problems is that going to cause? Well, we get a decrease in blood pressure. And so it could mean that it drops too low, and this causes the patient a problem, right? They stand up, they fall down. Why did they fall down? Because their blood pressure bottomed out. So again, when I see that a drug is an alpha blocker, I know that it's going to lower the blood pressure by dilating the vessels, and that a potential problem is hypotension, especially orthostatic hypotension. So it reminds me that, no, never mind, I was going to tell a joke. It doesn't really have anything to do with alpha blockers, but it's like saying, I don't have a drinking problem. I drink, I get drunk, I fall down. Well, I don't have a blood pressure problem. I take my alpha blocker, I stand up, I fall down. And it's because the blood pressure changes. Okay, so it probably wasn't really all that funny, but maybe it helps somebody make a connection. Moving on. Beta blockers. Now remember, beta-1 receptors are found only in the heart. When I block beta, then I'm going to slow the heart rate, because stimulating beta causes tachycardia, which, remember, epinephrine, beta-1 stimulants, I might want to raise the heart rate. The heart rate slows down too much, then I want to stimulate it. So if I block that on more epinephrine to the heart, then it slows it down. By slowing the heart rate, then I can lower blood pressure. Think about how that works. It's because it's going to decrease cardiac output. And if I'm not putting out as much volume, then there's not as much resistance. And by slowing the heart rate, it decreases the volume that's being put out. Beta-1 blockers are cardioselective. So they're primarily going to have an effect on the heart. Now, say this 10 times fast. Some beta blockers block both beta-1 and beta-2 receptors. This makes them non-selective. So if I block beta-1, which is found in the heart, then I'm going to decrease the heart rate. I'm going to decrease, cardiac output, which allows me to decrease blood pressure. How do you suppose that a beta blocker is used to treat angina? Well, remember, I've already told you that it decreases the heart rate. If I decrease the heart rate, that means that the heart muscle is not working as hard. If that muscle doesn't work as hard, it doesn't need as much blood supply. And if it doesn't need as much blood supply, then it's not going to hurt when it doesn't get that blood supply. And so therefore, I've decreased the angina, or angina, however you want to say it. And how does it treat cardiac arrhythmias? Again, I'm slowing the heart rate. If I impact the electrical conduction, then that is going to hopefully cause whatever poor impulse is happening to stop, and I get a regular rate and rhythm. Now, because they're non-selective, I'm going to get more side effects. And my side effects are primarily going to come because I'm blocking beta 2 receptors. Now, what does beta 2, if I stimulate beta 2, what does it do? Exactly, it causes bronchodilation. So if I block beta 2 from being stimulated, then I'm going to get bronchoconstriction. So that leads you to think, hopefully, what kind of patients would have a problem with this? Put your finger on your lip, because I just did. Alright, you can't see me, but it's kind of funny anyway. So, patients with asthma, patients with COPD, patients with pneumonia, these patients are going to have trouble. It's going to exacerbate their conditions. And so I need to be mindful of that as a nurse. So that's all we're going to talk about, just a brief overview of the adrenergic types and subtypes of receptors. But I think that if you really get a good understanding of these, where they work, how they work, what they're intended to do, whether it's to stimulate or to block, then you can truly understand the basis and carry it further when we're talking about drugs for hypertension, heart failure, dysrhythmias. So, thanks for listening. On to part 2.